to show something.
Yeah.
Just for the questions and all that, na?
Dr.
Yeah,
Shah, please.
I'll
Yes.
just show a few things. So I'm
Sir,
connecting online and I'll be handing it.
Shyam sir, we can go live now.
Okay.
Yeah.
Okay, we are going live.
Yeah,
Just
sir.
a minute.
Hello, sir. Good evening, sir.
Good evening, Dr. Pirajit.
Yes, sir. Good evening, sir.
You must be taking a noon nap.
No. I was feeling because I thought that it was yesterday.
No, Ravi, we are going live.
Okay.
Okay, so welcome everybody, and to begin with, I'll just show a disclaimer and how to ask questions. So let's get over with this, and then I'll hand it over to Dr. Dhawan. So we thank all our faculty for sharing their knowledge in this challenging time, and we wish our audience a healthy and safe day ahead. These webinars are dependent on internet speed, so there might be an issue. Please bear with us. You can also ask questions on the website. Here you can see us all. Just below the panel where you can see our videos, there is a question answer section where you can ask your questions. So over to you, Dhawan sir.
Okay. Thank you, Dr. Ashok Sham. And first of all, I welcome Dr. Ashok Sham. He has already spoken from the Ortho TV, because without his cooperation and providing us Ortho TV channel, it would not be possible to conduct this webinar. I also, welcome Dr. Shamsul Huda, who is associated with Ortho TV, and he's helping us with the webinar. I welcome our senior faculty, Dr. Mangal Parihar, Dr. Vasudevan, Dr. Arya Agarwal, Dr. Jitendra Bhatnagar, Dr. Jhunjhunwala, and speakers, Dr. Krishna Kumar, Dr. Rajiv Gupta, Dr. Priyajeet, Dr. Anupam, Dr. Karan Kukreja, Dr. Manish Prasad, and Dr. Arun Lal. So without wasting time, because we have so many speakers, I would request Dr. Rajiv Gupta to be ready with his PPT. Dr. Rajiv.
Yeah, ready, sir.
And the topic for today is metaphyseal deformity correction. So we have multiple cases. There is no lecture in this, only case presentation, and we will discuss over that. So I will encourage the audience to put as many questions as possible to make this webinar a very live and interesting. Dr. Rajiv Gupta, please.
Yeah. Good evening, all. First of all, I want to thank Asami India, Dr. Manish Dhawan sir, and my mentors, Dr. Mangal sir, Dr. Divya sir, Dr. P.N. Gupta sir, for providing me this opportunity. Today, I'm going to talk about the metaphyseal deformity in ipsilateral femur and tibia. So my patient she's a 27-year-old female, presented to us with complaint of right knee deformity, shortening and limping. She had some history of infection at 8 years of age, for which incision and drainage was done at that time. These were her clinical and x-rays at the time of presentation. So there is some juxta-articular deformity in the knee, in the right side of the knee. These are her lateral views, clinical pics and lateral x-ray. There is procurvatum in the distal femur. But on analysis, we found that there is a oblique joint line, and there is a distal femur valgus of 5 degree, and there is proximal tibia varus of 14 degree. LDFA has been decreased and MPT has also been decreased. And there is also shortening of up to the tune of 8 centimeter in the tibia. So these are opposite deformities. That's why the knee looks straight. And in the sagittal plane, there is a distal femur procurvatum of 19 degree. PDFA has been decreased from 83 to 64. And in the proximal tibia, there is also a 19 degree recurvatum. You can see the reverse slope. And there is a tibial shortening of 8 centimeter, as already discussed. The range of motion of knee is good, no laxity, no torsional issues. This was her walking video at the time of presentation. There is short limping gait. There is varus thrust. So we plan this case. First of all, we plan the different scenarios for this case. we find out the cora in the distal femur. The cora comes out to a little bit above the metaphysis. This is the planning with osteotomy rule number 1, where we have done the osteotomy at the level of cora only. And this is our planning with the osteotomy a little bit above the cora. This gives a little bit lateral translation. So this is the planning in the sagittal plane, same with osteotomy rule number 1 and osteotomy rule number 2. By following osteotomy rule number 2, we are getting some little lateral and proximal translation, jamming the fragments into each other. So this may add to the internal stability. So in planning of tibia in the coronal plane, because there is shortening and we are planning with the help of Lizarov. So for the stability of the proximal ring, we have to do the osteotomy below cora so that our proximal ring will be stable. This is the planning of proximal planning of tibia in the sagittal plane. Same osteotomy much below the cora. So plan for the femur is we will do the acute correction by the distal femur nail, and we will follow rule number 2 to jam the fragments for internal stability. For the tibia, we plan for gradual correction by Lizarov, following osteotomy rule number 2, which helps in the proximal ring transosseous elements fixation and stability. So this is our final plan. Now this is the execution of the plan. We go through the midline incision, patellar tendon approach. We put a wire entering at the level of 81 degree to the distal femoral line in the lateral plane, just anterior to the Blumenset line. We do the cannulated drill bit, enter the reamer, and we do the osteotomy a little bit above the cora as planned. This gives us the lateral and posterior translation. For the tibia, we put the proximal ring as per the deformity, as you see in the varus and the recurvatum, so that at the end of the correction, the rings will be parallel to each other. These are our post-op X-rays, the same as we planned. We have jammed the fragments into each other, providing internal stability. So these are the post-op X-rays of the tibia. The hinges are at the level of cora, and the osteotomy, osteotomy is below the level of cora, following osteotomy rule number 2. So these were her clinical pics post-operatively. So as there is a less space between the ring 1 and ring 2, we have not applied ortho-SUV frame in the initial part. We plan to distract it over the 4 rods for 3 weeks, and then we will start the angular correction for varus and the recurvatum. So these were her serial X-rays for angulation and translation correction. We can see that along with the dissection, the angulation is also corrected. At the end of 13 weeks, we get the rings parallel. So we again change to the straight rods and do just dissection. These are our lateral views. You can appreciate that for the correction of recurvatum, we are getting we are overcorrected the recurvatum and we are ending up into the procurvatum. So the patient has developed mild FFD and mild equinus, for his stretching was done and she has been improved. Then for the final correction, we use ortho-SUV frame. This is the planning for the ortho-SUV. We plan for slight valgus, slight recurvatum, and slight lengthening. And these are the X-rays at the end of ortho-SUV program completion. When we analyze these X-rays, everything is in the line. The LDFA is at the 90 degree. The MPT is in the line. The proximal distal femoral angle is good. The proximal posterior proximal tibial angle is good. There is just 1 centimeter shortening, and most of it is in the femur only because of jamming of fragments, but it is in the acceptable limit. So we remove the SUV and change to straight rods. This was their walking video. Then we will wait. We will focus on the stretching exercise of the knee and ankle and let the patient walk in a continuous fashion. These are a serial X-rays. The regenerate is well consolidating in AP view as well as in the lateral view. So after 11 months post-op, the regenerate is well consolidated. We have removed the fixator after stress test. These are our clinical pics. There is there is straight limb. And when after 1 year, we do the full length X-ray again and again calculate the angles. Everything seems good. And this is her walking video 1 year post-operatively. Luckily, we get a chance to get her X-rays after 2.5 years post-operatively. She came with some other pathology, and on comparison of these 2 X-rays, if we compare, this is the X-ray at the end of 1 year, and this is the X-ray at the end of 2.5 years. As per Wolff's law, the bone gets remodeled on the line of stresses only. If you can see, there is a letting down of the bone on the lateral cortex, and the medial side is reabsorbing. So lesson learned is good planning is half job done. In femur, internal stability at osteotomy should be the aim. You should get aim for 3-point fixation. For tibia, for complex corrections, yes, ortho-SUV frame can help everything together, but we can do the initial correction with hinges and later on use ortho-SUV frame for finer correction. Thank you.
Okay, thank you, Dr. Rajiv. Dr. Ankit Chauhan, please be ready with your presentation. Now, Dr. Rajiv Gupta's presentation is open for discussion. So, any questions for Dr. Rajiv Gupta?
Dr. Rajiv, please stop sharing.
Dr. Rajiv.
Yeah, sir.
So,
Yeah, sir. Good evening,
yeah,
sir.
actually, it's a good presentation, but the only thing is that the cora of the tibia was about the metaphyseal region. So the question arises, if you do the osteotomy stability, so for that nail in the condyles, we can put the another ring, and there are plenty of space into the femur. So because the lot of bump is there, so that can be avoided by doing the osteotomy at the tibia.
So, but that bump, that medial bump which you are talking about is not clinically significant, sir. I have shown the pictures. The patient is not having any trouble with that bump. And later on, when I have showed the 2.5 years post-operatively X-rays, that medial bump has reabsorbed, sir. There is a laying down of the bone on the lateral cortex only. And during the follow-up period also, the patient has not been complaining of that medial bump. It is not clinically significant.
Dr. Rajiv, for
Yes, sir.
benefit of the audience, because there are so many junior postgraduates, can you explain the osteotomy rule?
Yeah, sir. So there are 3 osteotomy rules. So there are 3 things in the line of deformity. One is cora, which is the natural property of any deformed bone. One is osteotomy, which is in the surgeon's hand, and one is ACA, that is angulation of correction of axis of angulation of correction. So when we put both osteotomy and our hinges ACA at the level of cora, then we are following the rule number 1. That will give us angular correction and there will be no translation. In osteotomy rule number 2, we put the hinges at the cora level, but we do the osteotomy away from the cora. Sir, anatomically there is a slight translation, but both the fragment axis will be collinear.
And the osteotomy rule number 3?
And osteotomy rule number 3, we will put both our hinges as well as osteotomy away from the cora. This will give us the secondary translation. There is the parallelness, there is a secondary translation present after the angulation correction, sir.
Okay, good. So basically this we were debating so that, it will benefit our audience because so many postgraduates are. Any other question for Dr. Rajiv Gupta? Dr. Mangal, your comment, please.
Dr. Manish, can I ask one thing?
Yeah, after Dr. Mangal. Dr. Mangal?
Yeah, no, I think that's a good presentation. We covered all the relevant points in terms of. So I think one of the points he made there was that he wanted to get good stability of the proximal fixation, and when you do that, your osteotomy naturally will go low. If you try to fix it above that cora, then you may not get that much stability, especially because there was, I think, a certain amount of lengthening involved over there. So this frame needs to be in for a long time. So you need good fixation on that proximal fragment. So and you have to remember that the further away you are, you get a bump, as Dr. Agarwal pointed out. But as long as that bump is not clinically sort of visible or creating trouble, over a couple of years, it more or less gets straight due to remodeling. So that's a good case.
Okay, and Dr. Anupam, now your question, please.
If the osteotomy would have been done the proximal, and after that, if it had been to prevent the bump, if that is a plate that has been suggested by some Dr. Agarwal sir, previous meeting there was a webinar. He has suggested if you like to prevent the bump, can put the plate and they can above that just you can osteotomize corticotomy. You could have done.
No, Anupam, we are talking about Elizurov here. He has not used plate. So why you want to use plate?
No, just to prevent that bump.
No. See,
one second, let me explain it. This bump is a required bump. When you do osteotomy rule number 2, if you don't get this translation, then mechanically your axis is not correct. So the only way to prevent the bump is to do the osteotomy at the cora, which in this case was very, very proximal, which would have created a problem in terms of getting a stable fixation on the proximal side.
That maybe created the another cora. That is double.
No, Dr. Anupam, actually this case was kept because to show that what are the osteotomy rules and how you should prevent. But actually the cora is coming at the level of knee joint. You cannot do your osteotomy at level of knee joint. That's why the osteotomy was done distally. Understand? Cora is actually in this case is at the knee joint. Very proximal, very proximal.
So we have fixed the proximal ring with 4 transosseous elements, sir. That needs space.
No, it's okay. See, we have to discuss because our viewers should know that what are the different osteotomy rules and how things behave. So this is a learning X-ray. Anything else, Dr. Anupam?
No, thank you.
Okay, and any other question for Dr. Rajiv?
Good evening, sir.
Yes, Shamshul, yes. And Dr. Anupam, I will tell you, the osteotomy rule, the translation is a good translation. So when you are doing translation is good, okay? Any other question, panelist? Dr. Ankit Chauhan, are you ready?
Dr. Ankit?
Yes, sir.
Please share your.
Yes, sir. Yes, sir. I'm ready. Okay, sir. Sir, my screen is visible?
Yeah, it is.
Okay. Good evening, everybody. This is Dr. Ankit Chauhan from Udaipur. My case for today's presentation is a valgus deformity of a distal femur. The patient was a 24-year male who presented with a genovalgum deformity of left lower limb. The deformity was first noticed at the age of around 10 to 12 years and gradually progressed till the age of around 18 years. There was no history of trauma around the knee or history or signs suggestive of infection around the knee. This was the clinical picture of the patient showing a valgus deformity of the left lower limb. So whenever we are going for deformity correction planning, first step is to go for X-ray. This was the first X-ray which I got when I ordered a full-length scanogram. As you can see, this is not an adequate X-ray. Both limbs are overlapping. The rotation is not correct, and all 6 joints are not visible. So first step is to get an accurate, correct X-ray. In case of valgus deformity, we need to get different X-rays of both limbs separately. So this is a much better X-ray now, showing the knee, ankle, and the hip joint separately. And the X-ray also showed 2 osteochondromas, one in the distal femur on the lateral surface and one in the proximal tibia on the medial surface. So this deformity is secondary to osteochondroma. Now, going for planning of the deformity and locating the deformity as is visible on the X-ray. This is not an acute angulation deformity, rather a gradual bowing of the femur bone. So in scenario 1, we can consider the different segments of the bow separately and plan for them separately. So in this scenario 1, I have drawn 3 axes. First is the mid-diaphyseal line of the proximal femur. Second is the mid-diaphyseal line of the middle fragment, which is the board fragment. And the third axis is the anatomical LDFA. These 3 axes are meeting at 2 points, which gives 2 cora. So in preoperative simulation, we can see that lateral open wedge correction at these 2 coras can give a centralized mechanical axis. This is apparently very difficult to do 2 osteotomies at this 2 level and to be able to fix them correctly. So instead of going for these 3 different axes, we can go for what is called as a resolution cora in the same X-ray. If we, for our planning purposes, skip this medial fragment and go for the proximal axis, which is the mid-diaphyseal line of the proximal femur and the anatomical LDFA. These 2 points are intersecting here, which can be considered as a resolution cora in between both of these 2 different coras. So this is the planning as per the resolution cora, which is showing a cora at the level of metadiaphyseal level. And this is orange line is the bisected line. This is more practical cora planning, so I'm more comfortable doing a osteotomy here so that I can get a more good fixation, and single osteotomy is more reliable to get correction. This is the pre-op simulation showing a open wedge correction on the lateral surface of 42 degree, which is bringing the mechanical axis to the center of the knee. This is a medial closed wedge planning of 40 degrees, which is also bringing the mechanical axis on the to the center of the knee. But you can see this is a large wedge which needs to be resected around 4 centimeter from the medial surface of the femur, and fixation in such cases is also going to be difficult, and also such acute correction runs risk of injuring the lateral popliteal nerve. So acute correction is going to be very difficult in this case. So when considering the options, for me the gradual correction looked a better option. For considering between Ilizaro or LRS, I went with Ilizaro because first it was a lateral, it was a distal deformity. Ilizaro offers a better fixation in the distal femur condyle, and also large deformity can be more reliably corrected with Ilizaro. Then we need to consider about reconstructed frame, where to put our hinges and motor, and do we need to go in for a tibial extension of the frame. Last question is whether to go for a prophylactic decompression of the lateral popliteal nerve. So coming to the construction of the frame, this was the frame which was pre-constructed and applied on the patient. Frame consists in the distal part of a one full ring, which was fixed in the distal femur with two Ilizaro wires and two shank screws, one from lateral side and one from medial side. As you can see, the distal lateral shank screw was deliberately put in an oblique fashion, starting inferiorly and progressing superiorly to get a more rigid hold in the distal fragment. The proximal part of the ring were fixed with 4 shank screws. This is the view of the fixation from different angles. As you can see on the lateral surface, the motor is on the dead lateral side of the frame. Because of all these elements coming in close together, there was no space to do an osteotomy from the lateral side. Therefore, the osteotomy was done in an open manner from the medial side. And 2 hinges were put, one anteriorly, one posteriorly, and these were placed at the level of cora. This is a second case with similar deformity, just to show that in this case, the deformity was much distal. There was no space between the 2 femur rings. So I had used a dummy ring. This ring has no fixation on the tibia. It was just used to connect the motor, because connecting the motor from the distal most to the middle ring was not possible. Then next is how to plan the osteotomy, how to decide the level of the osteotomy, and how to go in for the execution on table. So this was my planning of the osteotomy as per the preoperative planning. This is, I intend to do the osteotomy at the level of cora, so I intend to follow the osteotomy rule number 1. So this is how we can actually plan the level accurately before going in for the surgery. This shows me that my osteotomy line is going to be 7 centimeter proximal from the lateral joint line. Similarly, we can measure how much proximally it is going to be from the medial joint line. Then we can draw these lines on skin. And then as first step, I like to go in with the K-wire to mark the level of the osteotomy. And then when I'm going in for positioning my frame, I can make sure that my hinges are at the level of this wires, so that it means that my hinges are at the level of osteotomy, and I'm going to be following rule number 1. This was the immediate post-op picture. These are the pictures showing sequential distraction, which is gradually correcting the deformity over 2.5 months. This is clinical pictures over the duration of correction of the deformity. So deformity was corrected in 2.5 months, and the fixator was removed in 6 months. This is the clinical comparison before and after correction. This is the final X-ray after correction and the frame removal. Both side LDFA are now normalized. The tibia was preoperatively also normal. There was a residual shortening of 1.5 centimeter, which was actually diagnosed at the end of completion of the deformity correction. Patient was advised again to come back for changes in the rod, but he did not turn up, so this deformity remained. This was the gait of the patient before the surgery. And this is how the patient is walking now. This is 4 months after removal of the frame. And on the right hand side, you can see this is the range of the motion. He has gained around 70 degrees in 4 months after frame removal. I am hopeful he will gain more range as the time progresses. My messages from this case are that wherever going for a deformity correction, a proper complete X-ray is mandatory. There are multiple options to correct any deformity. We have to weigh and choose depending on the type of the case and our own experience. Resolution CORA in many cases offer a unique advantage, so that we can go in with a single osteotomy and gain equivalent outcomes at lower risks. CPN decompression prophylactically may not be required in all cases when you are going for a when you are going for large deformity correction distal femur, when you are doing it gradually. And with better planning, residual shortening and residual deformity could have been avoided. Like in this case, if I could have placed my hinges a little medial to the cortex of the bone, with correction of the deformity, I could have done more length. This is all from my side. Thank you, everyone.
Thank you, Dr. Ankit. And Dr. Krishna Kumar, please be ready with your presentation. And Dr. Ankit's presentation is now open for discussion.
Yeah.
Any questions for Dr. Ankit? Dr. Arya Agarwal, please.
I want to know how much the range of the knee joint, because that is a common question.
Sir, this is now 4 months post removal of the frame. Now he has up to 70 degree of range at the knee joint.
Is it because of medial condyle osteoarthritis or what? I mean, there was some arthrosis on the medial side, I think. You have not shown the last X-ray with the final X-ray of the joint, knee joint.
Okay. Sir, I'll show the presentation once again. Okay, so it's
there appears to be some arthrosis.
Just a minute, sir.
And that is the reason probably you do not have. However, you have done a wonderful planning. You have done a wonderful execution. I compliment for it.
So this is if my skin is visible, sir,
of the medial arthrosis as well. Otherwise, it would have become a perfect case.
Nagar, arthrosis does not lead to reduction in range of motion. Arthrosis leads to pain. And after you've done a deformity correction like this and put on a femoral frame, it takes up to a year for range of motion to come back. Does come back eventually. So his restriction at 70 degrees, 80 degrees at 4 months is okay. It's not because of arthritis. At this age, you don't get arthritis on the medial side in a valgus deformity.
But Dr. Bhatnagar,
and sir, if you can see the screen,
to tell about arthrosis, we should see the knee joint properly. We are not able to see because, so we cannot actually comment over arthrosis. What do you say, Dr. Mangal?
No, even without seeing the knee, you can say that in a valgus, you are not going to get medial arthritis.
Before, he has shown the preoperative clinical picture with a full range of knee movements.
Earlier, yes.
And he will get back all the movements. As Mangal rightly said, he will get back all the movements. And Ankit had done a wonderful planning. It was a perfect plan.
That is really perfect.
Perfect.
I appreciate it.
The only thing is that Dr. Ankit, you left 1.5 centimeter shortening, which you could have, planned. That was the only issue. Otherwise, I think everything looks perfect. Any other question for Dr. Ankit?
Ankit ko firing
sir,
1.5 centimeter soda.
Sir, if my screen is visible, I have this final X-ray on the horus. Is it visible to everybody?
Yeah,
I've shared the screen. This is
zoom in.
So this is the final X-ray. So this is the knee joint, which clearly shows there is no element of arthrosis as such.
Zoom it, my dear friend.
Okay, sir.
Zoom in, please.
Okay, so
you can select the photograph.
Zoom from my side.
You can select the photograph, click on the photograph, then you can zoom it.
Okay, sir. Just.
Will this patient can you listen, Dr. Ankit?
Dr. Ankit,
yes, sir.
Your screen is not there.
Dr. Ankit, Dr. Anupam has a question.
Just a minute, sir.
Just one.
So is the X-ray visible, sir, right now?
Yeah, it's visible.
This is the final.
So this is the same patient. Yes, the latest X-ray I have after the frame removal of the same patient.
Okay, okay. So probably Mangal is correct. You know,
There's a tilting of the fragment on the lateral side if you see it.
Sir, but joint line is parallel. It's
joint line, but in the
mechanical axis.
Eventually, with the time, this patient will end up with the secondary osteoarthritis because the mechanical axis is just moving towards the.
Mechanical axis is okay, sir. Mechanical axis is okay.
Mechanical axis is
No,
okay.
sir,
Can you
so if you want to go
full X-ray from the hip to knee?
Anupam,
Yeah.
you really should attend some deformity correction workshops.
No, sir. If you see this X-ray,
Axis. You see the X-ray. He showed the X-ray.
Sir, local bump doesn't matter.
Okay, sir. This
distal
is
part of this patient, distal fragment of this X-ray.
Sir, if
See the compare with this this opposite side.
Sir, if the mechanical axis is okay, then it doesn't matter.
What is the mechanical
sir,
axis?
I hope my screen is visible.
Yes, sir. It is visible, sir.
So your last
as you can see, sir.
Sir, we are.
See, Dr.
Hello.
Ankit, I know this. I've seen that your lines, your mechanical axis is okay. There's no problem.
Yeah.
No, it's really good, sir.
Now we can see it. It's good.
Yeah.
The only
Okay,
issue
thank
is
you.
mechanical axis is correct, anatomical axis is not correct.
Yeah.
We are not worried about anatomical axis.
Definitely, sir.
So, Dr. Ankit, can I have a question for benefit of the audience, because I have a question also. What is
Sure.
Fuji Sawa point?
Yes, sir.
What is Fuji Sawa point?
Fuji Sawa point actually is used when we are doing for high tibial osteotomy, correcting the varus deformity. So this is from his studies, Fuji Sawa pointed out that when the resultant mechanical axis is going through different portions of the lateral condyle, the longevity of the results obtained after STO differs. So at this particular point, which is he called as Fuji Sawa point, the longevity is maximum, and also the results in the effect of pain are maximum. So this is the line is calculated from the center of the tibial spine and the lateralmost part of the tibial condyle. This line is divided into different fragments. So the 40% of the distance from the center of the tibial spine to this lateral condyle is Fuji Sawa point, which gives a maximum benefit after STO if the resultant mechanical axis passes through this point.
Yeah, in other way that this actually point comes somewhere around the lateral tibial spine. And if you draw a line over the condyle, from medial condyle to the 62% as we go on the lateral side, which comes to the same what you have told, is the Fuji Sawa point. So just for clarification to the audience, because there was a question also.
Yeah,
So
make it very simple. When the mechanical axis goes through the Fuji Sawa point, the loading on both condyles are equal.
Yes, that is the point.
Yes.
So in a high tibial osteotomy, if you have to aim, you have to correct it to, try to correct it to Fuji Sawa.
It is usually 3 to 4 millimeter from the midpoint on the left
Okay,
side.
now Dr. Krishna Kumar, please share your screen.
Yeah. Is my voice clear?
Yes.
Right. So at the outset, let me thank Dr. Manish Dhawan, Mangal sir, and Asami India for giving me this opportunity. I'm presenting a case of metaphyseal deformity of the tibia. And this is a 32-year-old male patient who was having a deformity of the left leg since 2 years of age. He was working as a mason, was doing good with that deformity. He had some trivial trauma and some pain in the leg, for which he consulted a surgeon. And once the pain was subsided, he was operated for his deformity. And he was referred to me after 6 months of surgery. And this was the clinical picture with which he came to me. He had a 4-ring fixator on his leg, a short leg, if you can see closely, there is a small piece of bone that is visible on the middle of the leg through an incision, through which there was a little bit of discharge also. There was a deformity, something like a varus and a internal rotation deformity. And these are the x-rays. He has a deformity persisting. Lower end of fibula was resected and it was used to fill the gap, was fixed with 2 wires and a ring fixator. So this is the picture with which he was coming to me. And this was his original problem actually. He had a childhood infection, following which there was a pseudarthrosis and a hypertrophied fibula. He had this deformity since 2 years of age. So his present problems were a deformity in the coronal plane. He had rotation also and shortening. I was not sure about the stability of the ankle because the lower part of the fibula was resected. There was a discharging sinus and a small bit of dead bone was visible. So I was not sure whether the entire fibula was sequestrating or whether it was only the part of the fibula that was sequestrating. And he had a recovering foot drop. So my plan was to discuss with the patient regarding the need for multiple surgeries, wait and watch for the time being and see whether the fibula will heal or not. If it doesn't heal, my plan would be different. And if it heals, I can have a different plan. So I decided to plan for the further strategies after a small short period of time. During the next 3 months, these things happened. Like sequestrum came out, it was a small bit of bone. The wound healed with occasional discharge. Once in a while, there was a discharge. I removed the fixator at 9 months after the initial surgery and put him on a walking above knee cast. Removed the wire also after 3 months. The fibula healed well and the foot drop recovered. So that was his picture once the fixator and the wires were removed. So I decided to go with the second stage of the surgery. This was the amount of rotation that he had, around 35 degrees of rotational deformity also. The surgical plan was to put on a ring fixator, lengthen and varus correction with a hinge. I will use ortho SUV if required for the rotational correction as well as the lengthening. And if required, a second level osteotomy, but that will be decided after the rotational correction. I decided to be a little bit slow and steady because it was a difficult situation. And I'm not sure about the healing issues as well as the fate of the fibular graft once I do the corticotomy. So this was the X-ray planning. Proximally, I kept the MPTA as 87 degrees and distally, I just used a mid-diaphyseal line. I didn't use a full-length X-ray, only was planned on spot films. Planned for full-length X-rays after the rotational correction. So I applied a 3-ring fixator and did the correction with ortho SUV, did lengthening, rotational correction, and also the deformity correction. And this was how the picture was looking like after the correction. And I felt that the axis was passing through the center and I was pretty satisfied with this picture. I didn't go for the distal osteotomy at the moment. The corticotomy healed without any issues. And this was how the X-ray was looking after the fixator removal. Now I see that the deformity is undercorrected. There is actually a valgus. It's almost like a bowing deformity. And also some amount of rotation is left behind and also shortening. So I took him up for, and that is his function after the first surgery. I took him to the second stage. And what went wrong? What was the issue with my X-rays? So after the first surgery, the knee joint was not properly visible because I had to do osteotomy proximally. So I placed the proximal set of proximal rings and wires just distal to the joint. And there was actually rotation while I took the full length X-ray. You can see that this is a little bit externally rotated when I took the full length X-ray. So my calculation of the axis had gone wrong. And I was also not sure about the weight bearing status of the patient. So I failed to detect, or probably I didn't pay much attention to the distal deformity. Okay, so I took him again for one more stage of surgery where I applied a 3-ring fixator, did a 2-level osteotomy. Proximally, I used the ortho SUV and distally, I corrected the deformity with a hinge. And if required, I plan to do a fine tuning here once the correction was done with an ortho SUV. And that was the final correction. Now you can see that both osteotomies, the alignment is proper. The axis is passing through just lateral to the lateral tibial spine and the angles are corrected. So this was after the final stage of correction. A little bit of shortening and a little bit of rotation was under corrected. And this is 1 year post fixator removal. Both the osteotomies have healed and everything is looking fine. So what was different when I did the second surgery? I had better visualization of the knee because the proximal fragment was long, because I did a first stage lengthening there. I was able to place the ring, proximal most ring, a little bit more distal, and I used oblique pins, which gave me more freedom. So I was able to do with 3 rings. When I took the postoperative X-ray, I confirmed that he was weight bearing properly. And this time I had the courage to do the second level of osteotomy also, because after the first stage, I had a better understanding of the deformity, also a better understanding of the healing process, because even in the first stage, I didn't have any issues with the healing. Only problem was the rotation was a little bit undercorrected. So the lessons learned was in difficult deformities, you need a very careful planning. And it's always better to go for stage procedures, especially in those difficult congenital deformities and deformities with a greater degree of deformity. It's always better to go at a single step at a time. There is no harm in being a little bit overcautious. And whenever we are taking X-rays, it should be proper weight-bearing X-rays. And most importantly, you have to discuss with the patient about the procedure, because even though the treatment period was very long, in no point of time did he complain about the treatment. Thank you.
Thank you. And Dr. Krishna Kumar presentation is open for discussion, and I request Dr. Priyaji to be ready with his presentation. Dr.
So
Priyaji.
Krishna Kumar, if you get the same case again, how will you ensure that your rotation you correct properly? Means what was, you said you undercorrected, what was the issue? Did you not understand the correction? Why is the rotation undercorrected?
Actually, I didn't actually detect the I detected the rotational correction after probably after the removal of the fixator. There was a little bit of calculational error from my part.
Because it's a complicated case. You
how
are
much
not
was
very
the ankle
confident.
movement?
I think you are not very confident, Krishna Kumar. Second time, the confidence level has improved. So you could manage it with a double corticotomy.
Yes, very right, Dr. Vasudevan. But Dr. Krishna Kumar, if you are using ortho SUV and you are working on a software, you should aim to be as perfect as possible. Okay. And this case we have kept just to show everyone that you have to go to the basic principles of deformity correction. You should know the proper principles. And we have to show the cases where we have, suffered some difficulties, problems, or undercorrection. So that's why we can discuss it.
Yeah,
any other discussion?
Dr. Krishna Kumar, how much was the ankle movement after the final correction?
He has good range of ankle movement.
Well, it appears it may not be heavy, but it's really good if he had.
Well, I have to add something, that in terms of this rotation, usually the problem is in recognition. So there are 3 ways that you recognize. One is with the patella facing forward. Which side is the, how is the foot? Is it looking straight up, looking internal, external? That can be thrown off if the patient has some varus, if the patient has some adduction. So the second way of checking is what we call the thigh foot axis. Put the patient in a prone position, keep the ankle in neutral, and you should be able to see what is the angle of the foot relative to the femur. So it may be whether it is equal to the opposite side, what is known as the thigh foot angle. And if you are still in doubt, then use a CT scan so that you can see the anteversion of the neck, you can see the posterior condylar line in the femur, and you can see the transmalleolar line in the ankle. And looking at those 3, you can judge whether or not or how much rotation there is. Once you know how much rotation there is, using the ortho SUV, it's relatively easy to correct it.
But Mangal, it is
Probably the mistake that I committed was I relied on one single method for assessing the rotation. So if a case comes again, I would probably go with 2 methods. Cross check with one more method before going for the final thing.
Ultimately, I think Mangal, it depends upon clinical examination.
Yes, that's why the thigh foot axis should be done.
Krishna Kumar is a wonderful case, good case. And you have had a lot of learning experience in that case.
Thank you, sir.
Dr. Mangal, can I ask one question?
Yes, yes.
If there is any bending of the rod during the correction, is there any effect in lengthening? Bending of the rods?
While lengthening
There's a bend, meaning thereby if you have overcorrected it, more the range has been done by your assistant. So is there any effect on the lengthening or any deformity correction?
if the rods are bent, it usually means that there is a abnormal force being applied onto the regenerate. So it's not usually a good sign. That means there is some stress in the system which needs to be relieved. So you need to look at what is going wrong. You know, if you use hinges and motors the way these guys have been showing, if you notice, you will not find that there is any bending in the rod. Their rods are all straight. So if the rod is bending, for example, maybe there is premature consolidation happening or something like that. Or the patient is not turning all four rods.
It more. So that has to be corrected.
Okay, sir. Thank you.
Any other question for Dr. Krishna Kumar? Any other question? We go to Dr. Priyajit's presentation. Dr. Priyajit.
Manish sir?
Yes.
Is that ready with that? Oh, have you shown to Mangal sir?
What?
Wo brochure.
Yes, I've shown. I've already sent to Ashok Sham.
Okay.
He is just generating the link.
Okay. Okay.
I'll give you once I get it. Dr. Priyajit, please.
Is my screen is visible, sir?
Yeah,
yes, sir.
You can go ahead.
Thank you, sir. Good evening, my respected teachers and friends. Thank you for giving me opportunity to present my case. This is a case of a 39-year-old female with a history of road traffic accident, which was an open fracture, Castillo type 2, was treated locally by a debridement, primary closure and external fixation in December 2015. Then they planned for external fixator removal in 2016 January, treated later on with interlocking nail tibia in 2016 May. It was eventually get infected. They removed the nail, put again an external fixator and some antibiotic cement beads in August 2016. This is after removal of the antibiotic cement bead, and they removed the fixator in February 2017 and put a POP cast and allowed weight bearing. Gradually, she develops this deformity in 2018 May, and October 2018, this is the deformity which she presented to us. So we planned for correction of the deformity, which was in both plane and anteroposterior and lateral plane after exclusion of the infection, both clinically and by biomechanical study, which was a deformity in both plane. We planned for correction of the deformity in the universal protocol. Where is the deformity type, how much correction of the deformity, and methods of fixation and hardware. Step 1, we have taken the X-ray perpendicular to the plane of the deformity in AP and lateral plane to calculate the amount of deformity and the site of cora, which was around 40 degree of valgus and 30 degree of procarbatum deformity. Because it is a biplanar deformity, the step 2 was to treat as an oblique plane deformity. We used the Dr. Paley's method of deformity correction by graphic method. Here the 40 degree of valgus and 30 degree of procarbatum deformity. In the graph paper, we have drawn the both x-axis and y-axis perpendicular to each other, and it has an antero-posterior, medial and lateral side. And we have plotted this deformity according to the angle of the deformity, apex of the angle of the deformity, that is 40 degree of valgus deformity, that is 40 millimeter on the medial side, and 30 degree of procarbatum, that is 30 millimeter of the anterior side. Extension of the line and draw a rectangle and draw a diagonal. That is the measurement of the deformity. That is 50 here, lateral. And the same time, we have taken the X-ray at the deformity site on the tibia to determine AP and lateral diameter, and plotted in the graph paper replica of the tibia, and find out the convex side of the deformity. That is the direction of the arrow. Next, we plan for the deformity correction axis, that is the perpendicular to the plane of the deformity, and we place a over the graph, that is here 150, to see the position of the hinges, to count the number of the holes. Step 3 was to find out the level of fixation, level of hinge placement, level of motor placement, which is on the concave side, and pre-construction of the ring which hinges. This is the fixator after postoperative period. We have the taken X-ray perioperatively to a shoot-through fuse to see whether hinges are collinear or not. This is the postoperative clinical view. This is a postoperative X-ray while deformity correction is going on with motor. This is the X-ray of the fixator removal. Still some valgus deformity is persisting and with some residual ankle deformity. This is the clinical picture. And my take-home message is planning and execution must be accurate. Here, some residual valgus deformity is still persisting. In distal third deformity, X-ray of the ankle joint should be taken in both AP and lateral plane during follow-up to assess any ankle deformity. So in my case, there is some residual ankle deformity still persisting. Thank you, sir.
Thank you, Dr. Priyajit. And Dr. Priyajit's presentation is open for discussion. And I request Dr. Arun Lal to be ready with his presentation. Dr. Arun Lal. Okay, Dr. Priyajit's presentation is open for discussion now.
Yeah. Dr. Priyajit.
Yes.
Yeah, it's a nice presentation.
Thank you.
You have corrected the deformity. Only thing is there is a valgus deformity left. So later on it will lead to the arthritis. And the second thing is that you have applied one ring in the distal part of the fracture. So when it is a 2-point fixation, either when you are giving the one ring on the drop wire, so that was not given. So always have the 2-point fixation.
So the distal fragment was not that much big to apply more than one ring. And I have applied 3 wires, so I think that will give adequate fixation.
The 3 wires are the same plane. So it is always given better the 2 rings or 2-point fixation. 2-point fixation means 3 wires at the same ring and 1 drop wire. So that gives a better fixation.
Right.
Any other question for Dr. Priyajit from the panel?
Priyajit, very nice presentation.
Thank you.
Now, how do you assess yourself? How do you assess your case?
Sir, I must be must take X-rays during the follow-up with the ankle joint with a special concentration, because the ankle joint is not corrected that much. It's still some equinus and deformity is still persisting.
It would have been probably it's a weakness of the frame by not putting appropriate olive wires.
Right.
You have only 1 wire there.
Yes.
Probably you're not putting a drop wire with olives. So holding you can make the frame as strong as possible by using olive wire. That is the point I think Ram was telling about. So make it with the 1 ring, you make the frame very strong. Right. And look for any fixator loss. Suppose you have a 5-degree fixator loss, you just do a little overcorrection.
Right, sir.
When the rings are parallel, still bone may not be following it. You can do little more overcorrection.
Thank you, sir.
Okay. Any other comment from the panelist? Dr. Bangal?
No, I missed that. I got logged out by
Dr.
mistake.
Jhunjhunwala, yes, sir, Dr. Jhunjhunwala wants to ask a question. Dr. Jhunjhunwala, please.
Priyajit, just stop sharing your screen so the next person can come on.
Pin would have been much better for the lower end of the tibia. And the magnitude of the deformity was 50 degrees, as you have calculated. But you have done only about correction for 40 degrees. And that's why there was left out deformity. As our friend said, you should do 5 degrees extra so that you can get a proper correction. Thank you.
Could I add one more point, please?
Yes, go ahead.
Yes, the stability of the frame can be improved by adding a frame or 1 or 2 pins to the calcaneum or to the foot to improve the stability of the construct, since there is very little space available distal to the osteotomy. That is one way to reduce the residual deformity.
Okay. So, Dr. Arun Lal, you are
In
ready
this
with your
particular case, that was not required actually. This fragment is very large. In fragments which are half the size of this, we use one ring. So when you extend the frame across the foot, it has its consequences. So in a way, you are right that yes, you can improve the stability by extending across the ankle. But in a case like this, it's much better to use drop wires or maybe additional fixation, half pins away from the ring, etc. And you can get very good stability with that, as well as the use of olive wires, as Vasu and Dr. Arya Agarwal pointed out, to improve the stability good enough. The first issue is realization. If you are not able to see, if your x-rays don't show the distal tibia, you don't realize that I have undercorrected it.
Okay. Any other question, or we go to Dr. Arun Lal's presentation? Arun, please.
Yeah, am I audible, sir?
Yes, yes.
Oh, audible, sir.
Perfect. So good evening, everyone. First of all, I would like to thank the organizers for giving me an opportunity to present my case. So he is a 14-year-old male who presented to me in my outpatient with complaints of limping and deformity in the right lower limb. He met with an accident at the age of 7 and injured his right knee. It was an open injury. He had fractured his right femur, which was treated by open reduction internal fixation, and his knee injury was treated in a plaster cast. Parents noticed the progressive deformity in his right lower limb since then. Here are the clinical pictures, which shows a shortening of the right lower limb, flexion deformity at the knee, and genu varus. The patella was falling into a trough, which was formed in the knee. You can see on the video. Malalignment test in the frontal plane, it revealed an abnormal LDFA and MPTA. So there was a femoral varus and a compensatory valgus in the tibia. Sagittal plane analysis showed an abnormal PDFA causing a procurvatum of 33 degrees. So to summarize, in the femur, he had varus of 18 degrees, procurvatum of 33 degrees, and a shortening of 7 centimeters. And in the tibia, he had a valgus of 12 degrees and a shortening of 1 centimeter. I planned for a stage correction of the deformity, femoral correction first by the Lizaro method, followed by tibial correction. Since he was 14 years and I could see the physis still open, I also planned for an 8-plate fixation of the medial tibial physis at the time of femoral correction to see if any changes happens. So that's the femoral planning. It's an oblique plane deformity with a magnitude of 37.6 degrees. The plane of deformity was around 30 degrees lateral to the sagittal plane. That's the plane of the deformity. That's my femoral outline. That is my 200 mm ring. This is the hinge axis. And that's my pre-construct based on the calculations. So this is the patient on table. It's a 2-ring construct for the femur. The proximal ring was stabilized with 3 tapered shank screws in 3 different planes with an additional of an oblique pin to increase the stability. The distal ring was stabilized with 2 wires and 2 pins. This is the postoperative AP and oblique X-ray with the hinges superimposed. Osteotomy rule 2 was followed. That's the X-ray after correction of the deformity and lengthening. Varus and shortening in the femur was corrected in the first stage. As expected, guided growth didn't work in tibia. So these are the clinical pictures before femoral frame removal. The tibial deformity is completely revealed when the femoral varus was corrected. Femoral frame removal and tibial frame application was done simultaneously. A 3-ring construct was used. Osteotomy rule 2 followed. So this is the clinical picture and a full-length X-ray taken following tibial correction. We can see that the mechanical axis is passing through the center of the knee. Analysis showed complete correction of LDFA and MPTA. That is a progression of the tibial corticotomy site as it goes for union. These are the clinical pictures taken 2 weeks after removal of the frame. There was stiffness in the knee and his knee ROM was from 0 to 80 degrees. That is his gait after removal of the frame. To summarize, total duration of treatment was 1 year and 5 months. I could achieve complete correction of the femoral varus and tibial valgus. 2 centimeters of limb length discrepancy was persisting and shoe raise was given. He had a stiff knee with a range of motion from 0 to 80 degrees and was advised physiotherapy for the same. I paid price for the wrong pin which was inserted in the proximal femoral ring. That was the anterolateral pin. He had severe pain towards the end of distraction with premature consolidation happening when the rate was reduced. So I had to stop the femoral distraction by 1.5 centimeters. These are the clinical pictures sent by him to me 2 days back with a significant improvement in the knee range of motion and the near normal. So the take-home messages: preoperative assessment and proper planning is the route to success. The guided growth technique may not work in late pediatric age group, especially if the physis is sick. An MRI would have shown me the status of the physis and I could have avoided that part of my treatment. Stage procedures gives good outcomes as there is better soft tissue response, good compliance, and less confusion to the patient. Thank you.
Thank you. Thank you. Any questions for
So
Dr. Arun?
Second last slide, Arun. You said you paid the price for putting a wrong pin. Who paid the price? Patient. Yeah. I mean, we always say, let's take a chance. It's not you who's taking a chance. It's the patient who's taking a chance. All right. Now, I can see Manish listening. Manish Prasad, any questions, any suggestions? Karan, any questions, any suggestions?
It's a very nice presentation, sir, especially the time taken for the complete corrections and a very reasonable correction achieved and functional also.
Reasonable, kya kam raha bol, apart from the shortening?
Nothing else, sir, nothing much.
So good correction.
Perfect correction. This is 100% correction. Very nice.
Sir, I just wanted to discuss one point. Does a linear femoral correction lead to, like, is there something like every centimeter of you end up increasing a degree of valgus in the distal femur?
No, that's I studied that when I was doing my fellowship.
Yes.
Bhatnagar remembers. We did geometric things, and it's only after 10 centimeters of lengthening. The theory is that if you lengthen along the anatomic axis, you will cause medialization of the center of the knee. That happens only after 10 centimeters.
Yeah,
that time it was proven, and also now they are using all these implantable nails. Usme bhi there is no difference. So it doesn't matter. The other way, if you are worried about that, you can put your LRS parallel to the mechanical axis rather than the anatomic axis, but that's not a very efficient way of using the LRS. So I don't bother. I put it parallel to the anatomic axis and I lengthen. In these 5-6 centimeter lengthenings, it doesn't make a difference. Karan, any questions, comments? Bolo.
Yes.
Dr. Ankit, Dr. Anupam, be ready with your presentation. Dr. Anupam.
Yes, sir.
No comments.
अरे कुछ तो बोल Rajiv.
Dr. Vasudevan.
Would you do it exactly the same way? Would you do it differently? Would you do what he has done, or would you do something differently?
I won't be very sure about the epiphyseal part of it.
Okay.
Because it's quite close to growth completion, so it's not likely to work.
Right.
So I would have planned Elizero for femur and tibia both, not simultaneously but sequentially.
Okay.
Whereas everything else is same.
Why not simultaneously?
Chance of knee stiffness is much higher.
Absolutely.
Very difficult to.
You don't want to screw up the knee in that, because then they won't be able to get any range while they are on the fixator. But otherwise,
Yes.
you would do exactly more or less the same thing, right?
Yes, almost the same.
Anyone else different? Arun, apna Rajiv or Krishna Kumar?
Sir.
Anything different?
Hello.
Yeah.
Sir, only thing I would do differently is maybe not, instead of just one ring in the proximal femur, I'll put a full ring and a Italian arch. Anyways, he has gotten away with this, but I think doing a 5 or 7 centimeter lengthening, a more rigid fixation, more
that's
extended fixation was required in proximal femur.
He had to put that anterolateral pin because he didn't use the arch. If he had used the arch, he could have had more pins proximal and lateral or posterolateral, so they would not have, even at that level, at a higher level, if you use an anterolateral pin, it doesn't impede range of motion that much. An anterolateral pin in the distal femur versus an anterolateral pin in the middle of the femur versus an anterolateral pin in the proximal femur, they have entirely different effects on the muscle transfixion. Who else is there? Priyajit. Anything different? Any suggestions? Your mic is muted, Priyajit.
Ravi, please unmute.
Yeah, I'm making it. I'm making it.
Yeah. Priyajit, any suggestions? Any questions? Anything you would do differently?
No, sir. Thank you.
You noticed in this how the rings for that particular thing he was doing, the X-rays were showing the ring as one line, not as a sort of oblique thing.
Harshad sir?
Yeah. Can you hear me?
Yeah, you are audible. You are audible now.
Yeah, I think I've come first time now into this field. Yeah, that was a very good case. It was well done. The main thing that we look at, other than deformity correction, is getting maximum knee movement. So he has done it well. I have probably done similarly. Only I am used to putting a femoral arch compared to oblique half pins like what he has done.
I'm very novice to this ring fixation. Just one question to Dr. Mangal Parya.
Somebody has got their speaker on somewhere else.
Some echo is coming.
Yeah, it's very bad sound. So, I'm
okay.
Sir.
Is it okay?
Yeah.
Sir, is there any
Somebody is having
fix the any numbers of the ring?
Somebody is having
3, 4 or 3, 4, 5 or any sequence of this, or just you pin the science pin above, just to extend this ring.
Dr. Anupam, just a wait. Somebody has opened the YouTube simultaneously somewhere.
सबको mute करना तू.
I'm muted everyone, sir.
You muted everyone then.
I think okay, does not matter. We go to.
It's okay.
Dr. Anupam, you are ready?
Yeah, I'm ready.
Okay.
Good evening, everyone. Just giving me thanks and giving me the opportunity to speak and present a case in Asami webinar. I'll speak on the Cubitus valgus deformity in children. First of all, the greeting from the Varanasi.
उसको full screen करो. slideshow. Start
Dr.
slide.
Anupam, please put it on
Yeah,
slideshow.
I'm giving. Is okay now?
Yes, sir.
This carrying angle of the elbow, that is very important, is approximate 5 to 15 degree. The carrying angle is more in women than in men. Carrying angle is a greater in the throwing athlete. It's difficult to assess if there is a flexion contraction of the elbow. You cannot judge the carrying angle in the if the patient is having fixed flexion deformity of the around the elbow. There is a causes of the cubitus valgus deformity. There is a mostly it is a non-union of the lateral condyle, and there is a proximal migration of the lateral condyle. The cartilaginous articular surface of the distal fragments comes in contact with the bony surface of the proximal fragments. Second may be the cause the mal-united supracondylar fractures humerus. Third may be the osteonecrosis of the lateral trochlea. Progressive deformity that alter the elbow mechanics and causes the neurological involvement. Affects is mostly the tardial ulnar palsy. Axis, what we rely upon, there's a two axes that we usually calculate. There's the Kleb-Thurman angles. There is a second one is open hemisphere. Normally, if it is more than 90 degrees of varus, and if it is less than, there's a valgus deformity. And femoral ulnar angle is open hemisphere. Decrease is the most accurate. This is a case that a young boy has a 12-year presented with the following complaints: deformity around the right elbow, tingling and numbness in the little and half of the fingers, weakness in hand, grade 4 power. This is the case. This is a young boy that's having some problem in hand weakness and the neuropathy. So we have just gone for the NCV and EMG. There was some problem in the ulnar nerve. There's a neuropraxia is shown in the ulnar nerve C8 T1 distribution. So we have measured this angle, how much we have to correct. Normally just we have to be in under your 6 or 7 degree of the valgus. So photo was been taken, and just we have what next should be done. There's a lot of osteotomy is being performed, step cut, dome osteotomy is being done, Ellis Hazaro ring is being done. There is some osteotomy with a POPN. Few of us that we are doing the plating. Your management option depends on the school of thought, may vary according to your teaching institution, your expertise with this surgery. Depends on the need of the patient and his or her ailments, cosmetic look, neurological involvement, economical condition. I did the anterior transposition of the ulnar nerve and the simple medial closed vest osteotomy without any rigid fixation because of some my nasty about the plate in children in around the elbow or anything, because of I faced a lot of complication during my PhD studies, PG days. So still there is some fear phobia, but in result of this patient yielded very good. After 10th weeks, the removal of the implant and patient is doing full range of the movement. Summary was that the old standard treatment is still yielding excellent results. Not necessary that you are trained for the high tech, so we'll choose high cost implant or ornamental surgery. What basic needs to understand the logic of the surgery rather than mechanics. Don't underestimate the power of K-wires, the corona making us to rethink the orthopedics procedures before indulging into the surgery after the long lockdown. Take home message is that the cubitus valgus alone surgery is not needed until unless the patient require it for the cosmetic look. All they have a good range of the movement. Mostly we do for the neurological involvement like tardial palsy, implant like ring or plate, your preferred choice. But in my series, even without K-wire, all were yielded a good results. Thank you, sir.
Thank you, Dr. Anupam. Dr. Anupam's presentation is open for discussion. I request Dr. Manish Prasad to be ready with his presentation. Dr. Manish Prasad.
Yes, sir. I'm ready, sir. I also.
Okay. Dr. Agarwal, you can go ahead.
Yeah, Dr. Anupam, why you have done the transfer of the ulnar nerve? Because when we correct the angle, there is no need of the transfers of the ulnar nerve. That is the basic things.
So the main issue was the motor weakness. Was the patient was having a motor weakness that we need to. If you have seen my picture, there was a lot of stretching of the nerve was there. So there was an acute stretching. So we have admin to just open it that to have to the transfer, because that correction may take the lot of time. Till then the patient may end up then more weakness. I agree that it will correct in a long term, but anterior transposition was must in if the patient is having some neurological.
You are telling that you have done the acute correction.
Yeah, just we have not acute corrected, just we did the anterior transposition and medial close base.
No, deformity.
Just to correct the angle. Deformity was acute correction.
Acute correction.
Right.
So the problem is you're fixed with only wires.
Yeah.
Not sufficient to hold.
Dr. Anupam, may I ask something?
Yes, sir.
Sure. Sir, just two things. One is, I think in the last slide you mentioned that plate or wires may be your favorite technique, but in my case, did you wanted to write with K wires has resulted good results, or without K wires? It was mentioned without K wires.
Because mostly we used to assess the instability, the osteotomy. Sometimes there is some angulation, internal rotation of the fragment, distal fragment, just to combat that, just you have to fix it. Neither in 90% of my cases, there's no implant. Just we give the slab in extension and this corrected by osteoclasis and just replate.
In your case, sir, as you have used K wires in an intramedullary node, how much is the hold one is questionable? I mean, that is questionable, firstly. Secondly, have you ever thought of doing a dome osteotomy and fixing it with some cross K wires or something? Probably it will be more stable.
There was 3 cases that we have done it very earlier. There was some range of movement was defective.
Okay.
There was some range was not acceptable. The patient was annoying at the end of the surgery that I had full range of the movement. Just for the cosmetic surgery, he has landed with some restriction of the movement. So just we've been avoiding to do his implant in this around the elbow.
Anupam, how you have drawn the axis here?
Yeah.
How you have drawn the axis here?
Axis.
Yes.
Yeah, just we have gone to the along the shaft of the humerus and along the shaft of the ulna. That is the openings.
But what about the dynamic instability?
Dynamic instability was a pre-op and the post-op was accurate.
And what about the radiohumeral movement? Supination? Full.
There was a full, because the wire has been removed after the 10th week.
Did you use external plaster for that?
Yes, sir. Slab was given.
Yeah.
Sir, I agree with Dr. Ram Agrawal ji that you don't need a ulnar nerve transfer in this case. Because tardy ulnar nerve palsy, as soon as you correct the valgus, the tardy part is gone.
And
yes.
Also, there are papers
the stretching part is gone.
Which say that when you strip the ulnar nerve for this anterior transposition, you are in fact disturbing the vascular.
Dr. Mangal, we are not able to hear you. Dr. Mangal, can you come closer?
There are papers which say about, when you strip the ulnar nerve, you are disturbing the blood supply, and that in itself leads to problems with the ulnar nerve. So it's a question mark. There is, the jury is out on that, whether you should do. Earlier, it used to be taught that you should do anterior transposition. I almost never do it now. I try and reposition it back into the same bed.
Okay.
I have a question, sir, to Dr. Anupam.
I have a series of my 18 cases that have been till now without implant. I have 7 cases with K-wire, I have 6 cases and 3 cases with plate. The most of the complications just we have in a plate and ring. So we are now divided to use this plant because some constraint, there's some patient complaint about this ring, and I have one infection in a plate cases that as patient landed with some osteomyelitis. So just to avoid this implant around this Cubitus cases in varus or valgus, we used to use in varus cases. Yes, we used to use the plate, but in valgus cases we avoided to use it.
Okay.
Yeah, Dr. Shah here. Can I ask one question? In
Yes, sir,
how
yes,
many
sir.
cases, what is the result that you have got? How many cases have failed because of using implants which do not hold it in exact position?
Without implant, every case was 100% perfect. With implant, there was some 30% was a complication in a form of restriction of the movement, infection of the around the operative site, some discharging sinus was there, some
Because this is, can I comment please?
Implant,
Anupam,
I like to say,
Anupam.
sir.
Dr. Anupam, can I comment please? You generally get this deformity by using 2 K wires and close reduction for a fresh fracture.
No,
sir, definitely, sir.
Well,
no.
That's the commonest way of getting this. So again, you're doing an osteotomy and using 2 wires.
No, it was because
I think
this case was something having instability.
well in your hands, fine.
Just for the holding this osteotomy set as we put the 2K wire.
All right, I won't venture to do like that.
Okay, we'll go to Dr. Manish Prasad presentation. Dr. Manish Prasad is a young telegraph surgeon from AFMC Pune. He is Lieutenant Colonel in the Army and he is also Associate Professor. Please everyone mute yourself. Dr. Manish Prasad is a Lieutenant Colonel in Army and he is also Associate Professor at AFMC Pune.
Manish
Dr.
sir.
Manish, yes.
Manish sir.
Yes, sir.
Your sound is echoing actually.
Okay, now?
It's still.
Okay, I'll tell Manish Prasad to go ahead.
Sir, am I audible, sir?
Yeah, Dr. Manish, go ahead, please.
Good evening, everybody. Special thanks to Dr. Dhawan, Mangal sir, and everyone, all senior faculty for giving me an opportunity and having a representation from the Army. I'm going to dedicate this case to Dhawan sir, as under guidance of him only I did this. It's a case of a 12-year-old boy with a proximal tibial varus deformity who was symptomatic with pain and difficulty in prolonged standing and trying to jog. Now, hello sir, can you hear me?
Yes, we can hear you.
Please go ahead, Dr. Manish.
Please go ahead.
I'm not able to advance my slides, sir, somehow.
On the lower panel, on the lower side, there is the.
Or use your arrow key.
Yeah.
Or use your arrow key, yeah.
I'm doing it, but it's somehow got stuck, sir.
No, it will move. It will move.
Just, yeah, it's moving now. So here are the preoperative clinical pictures, sir. As you notice, the habitus of the patient, he's an obese adolescent guy, probably a case of an adolescent tibia vara. So clinically, I would like to mention that if you see this middle image, there is an apparent proximal, there is an apparent varus deformity around the left knee region. On the left side, on this image, you see from the side, he doesn't have any hyperextension on any fixed flexion deformity, any apparent thing like that in the knee, sir. So it's basic teaching and quoting Dror, Pelly and Herzenberg. Whenever we think about a deformity and its correction, we go with an algorithm, something like a mnemonic. It is called map the ABC, where these letters stand for measuring the mechanical axis, analyzing the joint angles, picking up the specific bones where the deformity is there, And then to plan the correction, we look for the apex of the deformity where it exactly is, and then we plan our site of osteotomy as per the rules of osteotomy, and then we go for the corrective modalities wherein we have acute correction methods as well as gradual correction methods like various fixator systems. So going with the same, if you see here, we can clearly see that the centers of the hip, knee, as well as the ankle in the left limb are not collinear, meaning that there is a major medial deviation of the mechanical axis medial to the knee center. So there is a mechanical axis deviation. That part is clear. Now, of course, by measuring the various angles, we know that which part is normal, which part is abnormal. And then these particular lines in my X-ray, the way they have been plotted, they show them. We know that there is a deformity somewhere in the tibia, upper tibia. And then one of the methods of assessing the metaphyseal tibial deformity is by extrapolating the mechanical axis of the femur to the tibia, and then taking the mechanical axis of the tibial lower fragment from the center of the ankle up, and the point of intersection, that is this place, we get the apex of the deformity. So in this case, we have a 15 degrees varus deformity of the proximal tibia. Now,
Dr. Manish,
yes,
can you go to the previous slide and tell the viewers that if you have to do mechanical axis planning of the femur,
yes,
what is the way, how these lines are drawn?
So we go with the joint, the joint orientation angles we make, and then we take the mechanical axis of the femur over here. We plot as
I'll explain. Sorry. What you do first, you draw the anatomic axis of the, how to find mechanical axis of the femur. You draw the anatomic axis of the femur, and once you have drawn it, you draw a line parallel to the dotted line parallel to from the center of the hip down. And when you make a 7 degree line to this point, it is the mechanical axis.
Yes,
which you have extended down. So this case was actually kept because in the last webinar there was some what is anatomic and what is the mechanical axis planning of the femur. So this is the way, easy way to do the mechanical axis planning of the femur. Okay, now you can continue.
And the same, and this way, sir, if we get the mechanical axis and if we have a deformity in the proximal tibia, it is also described that if we just extrapolate this and let the mechanical axis of tibia intersect it, we are able to find a better cora for the upper tibial deformity. So coming to the next slide, as I mentioned, clinically, he did not have any FFD or any hyperextension. Clinically, there was no ligament laxity on examination of the knee. But still, if you see on the lateral, the sagittal view also, we have plotted the to find out any kind of bony deformity in the distal femur or the proximal tibia. We have tried to find out the posterior lower femoral angle and the posterior upper tibial angle, and we find that both of them are within the normal range. So it was decided to go for a deformity correction over here. And because in the previous X-rays you would have noticed there was hardly, though he is a 12-year-old guy, but there was hardly any scope for growth in the on the lateral side. So we did not go for any guided growth method. We decided to go for a gradual correction using a circular fixator. In this case, Taylor special frame was applied with a 5/8 ring on top and full ring down below. With it, and it was an all wire construct. Here, the advantage of this is that we can give it a very stable fixation, and we can still perform. We can perform the osteotomy at or very near to the cora, which leaves the upper fragment very small, and we can have a very stable fixation using this TSF. So these are the various follow-up X-rays. The individual also had around 1.5 centimeters of shortening in the tibia, and gradually we, as per the computer software program, the varus deformity as well as the shortening also were addressed. And these are the further follow-up X-rays. The patient with the fixator in situ. And over here, these are the actual X-rays, the scanograms which have been taken after removal of the fixator and once the bone has healed with good callus formation. As a comparison, this one is the pre-op picture wherein there was a significant mechanical axis deviation, And with the surgery and with the procedure, the corrective procedure which has been performed, there has been a significant improvement in the mechanical access of the left lower limb. These were the post-op follow-up. This is 3 months after the fixator was removed, and the child is on follow-up now for the last 1.5, almost 18 months. He is doing well.
Dr. Manish, can I add?
Yes.
Actually, this deformity is under-corrected. Actually, the tailor spatial frame was applied and it was corrected. But what happens that I did a mistake, or I should have over-corrected it, because it's a heavy child. So the correction, there was a loss in the correction. So if you can see, the mechanical axis on the left side is still on the medial side. But though because of loss in the correction after removal of the tailor spatial frame, so it is sometimes recommended that you overcorrect, and which Dr. Mangal also says when he does the high tibial osteotomy. So I should have overcorrected, and there was a loss in the correction after removal of the frame because it is a very heavy child. So now it is open for discussion.
In addition, he is having a internal tibial torsion also.
Yes, yes. No, torsion improved, but only thing is that I lost correction after removal of the frame. So any questions or any to discuss?
Well,
Yes.
Long X-ray, Manish, long X-ray took were not corrected. Patella is outward in both the previous and the post correction.
No, he has the varus deformity on the right side also, the normal side also the varus deformity. I told
that
him
is all.
that
There's a remaining varus deformity. Apart from that, X-rays are not also perfect. The patella is looking on the lateral condyle. That is not the right way to do X-ray and calculate according to that. One must have patella on the center of the knee joint.
Manish sir.
Dr. Mangal, your comment, sir. Yes.
Manish sir, Mangal sir is trying to say something. He's just pointing out
Dr. Mangal, please. Mangal.
I already said it. Look at that arrow there.
Yeah, that's why. That's why I'm saying, sir.
These X-rays are in external rotation. So I suspect that the amount of correction that was planned was less than required because the X-ray was not perfect. So you have done a perfect correction, meaning you planned for 7 degrees, you got 7 degrees, but the 7 degrees was not enough because it was on an X-ray which was not perfectly done.
Yes, very well, sir.
This is always a problem with the technicians. The technicians are trained to put the foot forward.
Yeah, definitely, sir.
And you have to oftentimes, get them to understand that keep the patella forward. That's number one. Number two is, if you see this post-operative X-ray and you see the pre-operative X-ray, you will find that his right side varus seems to have corrected. The blue line is in the center of the femur and the red line on the left side is showing varus. That's because this is a chubby boy. Both his legs don't fit on and the radiographer squeezes the legs together. You notice this, you notice the overlap of the soft tissue shadow.
Yes, it is more evident on the post-op X-ray, sir.
It's you can see it here.
Yes, sir. It is.
Right. So in such cases, then you have to do one leg at a time.
Yes.
Thank you, Dr. Mangal. And Dr. Manish Prasad has done Asami Inland Fellowship at Gangaram for 2 months, and then he was selected candidate to go to Austria. So he has gone on Asami Fellowship in Austria for 4 weeks. So it is important for the audience that Asami provides international fellowships. So the selection is usually done at Asami Con, which is held every year. So can we go? Can I request Dr.
Manish, probably this X-ray has some amount of shortening still persisting, apart from varus.
No, there is no shortening. There is no.
There
shortening.
is.
No, it's not. Shortening is not there. Yes, varus I agree because I lost the
there is a shortening. Yeah. Anyway, ask him to take an X-ray with the.
We will call him again. Dr. Karan, please be ready with your, Dr. Karan. Dr. Karan Kokreja, can you hear me?
Yeah, I can hear. I'm just unmuting.
Dr. Jhunjhunwala has a comment to make. Dr. Jhunjhunwala.
Dr. Manish, please unshare. Please stop sharing.
Where does it, sir? I'm not able to.
On the top. On the top. On top.
View option there.
On top.
Posture. Yes.
Just let me do.
Okay.
I've done.
Thank you, sir.
Dr. Karan, put your presentation, and Dr. Jhunjhunwala had a comment. Dr. Jhunjhunwala, please.
Yeah, Dr. Manish, can I ask you one question in the meantime?
Yeah.
How do you prevent the deformity from increasing after removing the fixator?
How do you prevent?
You lost some correction, isn't it? Then the whole idea is putting the fixator and getting a correction, and you lose that to 7 degrees.
Actually, because what happens, I have faced this problem because the area is a cancellous bone, the patient is overweight. If the patient is overweight, so it is once you remove the fixator, you do not allow full weight bearing to the patient, and if partial weight bearing is done for some like 6 weeks, I think we can avoid this thing, or do a overcorrection, slight overcorrection when you are doing this correction.
Can I comment?
Does the dome osteotomy help? Manish?
Yes, doctor. Yes.
Does the dome osteotomy help in such cases?
Yes, it does help.
I personally feel there the equal results are there. Only the thing is that you have to correct that 2-3 degree. And my experience is, if the patient is quite obese, so you have to correct 1 or 2 degrees more. Otherwise, due to weight, against recurrence of the deformity takes place.
Just
in that case,
can I ask one question, Dr. Manish?
Manish, in that case, we must aim for at least 4 degrees of valgus.
Yes, you are very correct.
Yeah.
Very correct. This case was shown because, this problem we encountered. So it is better to show to the viewers that what problem, our discussion should be tell the audience that what problem we faced and what you should avoid. So this is the whole purpose of this webinar. So any other question? Otherwise we go.
One question, Dr. Manish. This is a small construct, or it should be the larger, longer construct would have helped?
No, this is Taylor special frame.
Taylor brace, Dr. Manish has got the scholarship of Asami and Australia, where he learned this technique. You should also take the opportunity.
Sir, this is
I'll answer this. Dr. Anupam, this is Taylor special frame. This is not, so Taylor special frame is a very, very strong assembly. The pins are etch-coated, the wires are very strong, and the rings are also very strong. They are made of aluminum, and it is made of aircraft grade aluminum. So it is very strong. You require 2 rings only. But you have to understand that each ring, you have to have a 5-point of either wire. You can use around 3 wires and 1 pin at least, so that the frame is strong.
Manish, it is not the frame which matters, it is the hold on the bone which matters.
The hold, yes.
Yes, very good. Okay, Dr. Karan, can we go ahead with your presentation?
Can you all see my screen?
And Dr. Arya Agarwal, you'll be ready after Dr. Karan. Dr. Arya Agarwal, you'll be ready after Dr. Karan.
Some echoing happening. Some echoing is happening.
Yeah, some echoing in the system because every voice is echoing. Okay, Dr. Karan, can you start?
Yes. Is the screen visible to everybody?
Yeah, please go ahead.
Yes, we can see.
Okay. So I was just sharing a case report of a 26-year-old male with a post-osteomyelitis growth arrest, with a severe deformity. and the deformity was severe enough to result in a compensated valgus of the hind foot, and he had to subluxate his knee to allow him to walk. In addition, he had 8 centimeters of shortening, and he also had a full range of knee movement. So this is his preoperative clinical pictures. So this is when you reduce the knee. This is how the leg used to look. And the X-ray is unfortunately not clear enough. Neither were the scanograms. And in fact, when you had planned the surgery for deformity correction with the X-rays, the plan had to be changed intraoperatively because of this. There's a vast difference between what we saw on the X-ray and what we saw on the C-arm at the time of surgery after reducing the knee joint. So we realized that the X-ray and the scanogram both were quite inaccurate because of the way the X-ray was taken or the scanogram was taken. We cannot reduce the knee joint and get a focused X-ray or scanogram on the center of the knee joint. So when we did that at the time of surgery, we got a good idea of what the deformity was. He was advised knee arthrodesis by quite a few doctors, but he wanted a mobile and painless, because he had a painless knee, we thought we'll give him a chance. And the X-ray and the C-arm confirmed that the joint was healthy. He had severe MCL laxity, which we planned to correct at the second stage. So the correction that was needed was quite a lot. It was It was 57 degrees of varus and a 39 degrees of recurvatum was correction was needed. So this is how the clinical picture post-operatively was. So it's planned for 1 ring proximal, 2 rings distally. This is the osteotomy site, and which is much distal to the cora. So planned for osteotomy rule 2. So this is how it looked, and this is the cora which we calculated intraoperatively, both on the AP and lateral view. So a lot of it had to be done freehand calculation during the surgery. Once the correction was achieved, we did the lengthening. Okay, so you can see that there's a bone. The proximal fragment is far away from the distal one. That is, the cut ends of the bone are very far apart, which resulted in a little poor regenerate for quite a few months, which did bone grafting. But finally, we got a good alignment of the knee, of the limb, and got a good regenerate also, which was a little delayed. Regenerate required bone grafting, and even after that, it took 13 months for it to heal fully. So this is a final picture, a 2 years follow-up, where I got a good alignment. The angles are well restored, both on the AP and the lateral view. And this is the video. This is how he was walking before surgery. And this is how he's walking before, after. So the problems faced during the surgery was a poor radiological assessment because of the knee subluxation. So the whole surgery had to be planned intraoperatively. All the angles had to be calculated. The cora had to be calculated freehand. Fortunately, I got a little lucky that the translation was minimal. That means we managed to get the hinges very close to or on the cora in both the AP and lateral view. Okay, and the cora was quite close to the joint line. So it was proximal to the proximal ring, because of which the hinges had to be placed like this. So we had to connect the hinges with the post proximal to the ring to ensure that the hinges match the cora correctly. And the other difficulty we faced was the placement of the wires, pins, and hinges because of severe deformity. So over to the panel for discussion.
Thank you, Dr. Karan. Now, Dr. Karan's presentation is open for discussion, and I request Dr. Arya Agarwal to be ready with his presentation. Dr. Arya Agarwal and Dr. Jhunjhunwala. So first, Dr. Arya Agarwal.
Harshad,
yes.
Harshad, you are connected by 2 machines.
Yes.
You are giving feedback, so please put off one of them.
Okay.
Either your phone or your laptop.
Yeah, I have off my phone.
I think now it is okay.
It's still an echo.
Dr. Ravi Chauhan told me. Can you listen? Here. Hello.
Yes,
hello.
We can listen, sir.
Yeah, Dr. Karan, my congratulations to you. You have done a very difficult case beautifully. Well done.
Thank you, sir. Thank you, sir.
Right. Good.
One question, Dr. Karan.
Yes.
There was any laxity of the ligament on the lateral side?
Yes, he had a lot of laxity before the surgery.
Yeah.
But I think luck was on his side, and he did not have any clinical instability when he came back for a follow-up. And he didn't even allow for a MRI scan to assess the ligaments of the knee. He said, "I'm totally all right. I don't want any knee surgery," because he was planned for later on the second stage MCL reconstruction, maybe an ACL, PCL. We're not sure which is lax. But clinical laxity improved a lot after the deformity correction. Even his hind foot also improved a lot. You can see that
CPN was not involved during surgery.
No, not involved at all.
It's been saved.
Even the hind foot also, valgus, still valgus is
Doing
persistent,
good.
but and there's cavus also, but they are all clinically not giving any issue. He's very comfortable and he's asymptomatic there.
Karan, very nice correction, very good.
Thanks.
But have you assessed the final X-ray yourself? Are you 100% happy with it?
No, there is a slight translation.
Yeah.
And
look very
what
carefully.
was the posterior angle, posterior tibial angle, slope?
Posterior.
How much was the posterior slope?
It is 80 degrees. So it's about 10 degrees slope is there.
10 degree was there?
And there's an anterior translation.
Yes, there's a slight translation.
But overall, it's good.
It's really wonderful.
We must improve upon the result which we are having. Next time when you get it, we must improve better than this.
Yes, but I was very happy with this for the freehand correction because I expected to need at least 2-3 adjustments of the frame to ensure that the correction is good.
Yeah.
But I was a little lucky that when the AP view correction achieved, the lateral view correction also was achieved.
Don't depend on lucky. You must expect yourself and depend.
It was good planning and good execution.
Good.
There's no real planning. The whole pre-op planning graphs had to be thrown in the dustbin because the intraoperative image was very different from the X-ray. The deformity is much more different, and the oblique plane in which it was also a different plane. So I had to do a lot of freehand eyeballing in the OT. So that is why I was little apprehensive about the result.
Here the line which you are drawn on the tibia,
yes,
the mechanical axis, is not starting from the tibial line, middle point. We're taken to the more medial.
Yes, it is slightly medial still.
Yeah, but you must start it in the exact position. And in the APV again, it is not in the anterior tip of the articular surface. It has to be 1 feet.
No, this is just the distal part. This line is going distal.
Yeah, where is the proximal?
Showing where it's interacting. Yes, proximal I have not drawn.
It has to go here.
It has to go here. Yes, that's the translation that is residual.
And again,
so now if you draw your line like this, your MPTA will be less than 86. When your line comes like this,
yes,
it becomes a little more varus.
Mangal, patella is on the lateral condyle again.
Yeah,
it's not centered.
Karan, just go back to your pre-operative X-rays. Right now, when you want to go for an X-ray of this patient,
yes,
next time, how will you prevent this problem happening?
I'll have to basically supervise the X-ray myself and ensure that the knee is reduced and
there's nothing wrong with the knee.
Yes, but it is only when the leg is held in this position was the patella facing forward, which was never being done by the technician.
Still it is rotated.
Go back one. Oh, show me the X-ray. Yeah.
Yes.
Now, when you do a full length X-ray, so this guy probably, if you go to the clinical picture, one you put right. Now here, what you are seeing is you ignore this portion. Ignore this portion. Just look at the distal femur and the proximal tibia. What do you see?
There is a flexion.
Absolutely. So you are seeing a flexion deformity of the knee, compensated by a recurvatum of the tibia.
Yes.
Right? Now, if you want to do an X-ray and find out what is the MPTA, you will have to keep your X-ray there down and do the X-ray in this direction, like this. One second, I'll just something like this in this direction, vertical to the tibia.
There is a compensation in the knee joint. Yes.
In addition to the full length X-ray, you have to do kind of full bone X-rays where the beam is parallel to the joint here.
Yes.
And then you will get a proper MPTA. Then you will not have to eyeball on table because you will have a better understanding of what is the MPTA and what is the recurvator. So one more thing that can happen in this case now is if you go to the last X-ray, so now I tell you that this guy still has a flexion deformity.
Yeah.
How will you prove that it is not?
You take a standing lateral view scanogram.
No, you have to take a full
Not only
extension.
just a lateral in full extension. So when you do that, if you clinically you see he has a little bit of flexion, and if you do a lateral X-ray in maximum extension, that will show you whether or not or how much you have. So pre-operatively as well as post-operatively, we can check what we are doing in a more precise manner so that the next time we are not having the same problem.
Yes.
But well, difficult case, given everything else, well corrected.
Yes. Thank you, sir.
Okay. Dr. Arya Agarwal, are you ready with your presentation?
I am ready.
One last final one to make your presentation even better. That post-operative clinical picture would have been better with his pants up.
Yes. Thank you, sir.
Okay, sir. Can I present now?
Yeah.
Okay. So I'm going to tell about the correction of post-traumatic cubitus varus deformity with the Ulnar method. Cubitus varus is the most common complication of the supracondylar fracture in children. Cubitus varus has three components: varus, internal rotation, and hyperextension. Correction is done by supracondylar osteotomy and is stabilized by Ulnar fixator with juxta-articular hinges. The carrying of the normal, this is the case who was having the 38 degree of the deformity. What happened that this is the fracture takes at the supracondylar. So the cora is at the oblique fossa. All supracondylar take the fracture at the oblique fossa. So what happens? So cora is within the oblique fossa. The osteotomy cannot perform at the level of the cora. Osteotomy performed above the oblique fossa. Following the principle of osteotomy rule 2, we have applied the juxta-articular hinges. This is the bone model which we are showing here. We are applying the juxta-articular hinges. And after that, you can see that this is the juxta-articular hinges. This is the how much deformity to be corrected. This is the angulation of the deformity. That is the deformity varus plus normal curling angle. That is summation of that, the axial view of that. What happens? First of all, we do drilling for the osteotomy because if you do not do the drilling, there may be the shattering of the fragments. So your oblique fossa may be damaged. So always do the drilling of the 2 mm little bit. And after that, we correct the osteotomy because this is osteotomy rule 2. We have to do the medial translation of the fragment. So by this juxta-articular, we do the medial translation of the fragment. And after that, you can see that this is the 1.5. This is the whole thing is percutaneous. Under C-arm, 1.5 meter incision along the lateral supracondylar ridge. And you can see basically that after the deformity gradually corrected, there is a medial translation of the deformity. And this is the initial angle was 38 degree. Normal measurement, the correct is the humeral elbow wrist measurement. That is correct there. This angle is the humeral midline. This is at the radial tuberosity. It is at the maximum curvature of the radius. We draw a line. There are so many measurements are there, but best is the humerus elbow wrist hinge. Now you can see beautifully the deformity is very well corrected. 8 degrees of the valgus has been achieved. And if you see the mechanical axis line, it's a medial translation. This is lateral angle. So it was before surgery. You can see that full extension is there. The deformity is fully corrected. This is the front view. This is the side view. And full amount of the flexion of the elbows are achieved. This is the 18-year boy is there. So it was a difficult case. So this is the bone model. We pass the wire from the posterolateral to anteromedial surface, and pre-constricted femur attached to the and first early wire is tight there. And after that, the whole after correction, we correct the varus deformity. Then after that, because we have find out that all the deformities that is varus and internal rotation. If you correct that, so there become lot of problems. The bone is displaced. So what we do, first of all, we correct the varus deformity, and after 1 or 2 weeks, when the callus has started form, so we do the derotational deformity. This is the way we remove the hinges there. And after that, what we do, we put this thread rod into the clockwise rotation. So what we do, we put this rod, all the rods over in the clockwise in next hole. And after that, what we do, we tie this. So what happens that there is a derotation of the fragment. Whatever internal rotation is there, gradually corrected. And after the summary, juxta-articular hinge are applied to the medial translation because of the cora is at the olecranon fossa. The osteotomy gradually an internal rotation is corrected. After correction of the varus deformity, when a soft callus is formed, rotating distal anti-clockwise will produce the 10-degree external rotation. Now I'm going to show the movie. So this is a bone model of the cubitus varus deformity. You can see we applied the pre-concentrated frame following 2 hinges with the juxta-articular hinges. And after that, gradually by motor unit, we are correcting the deformity. So angulation is corrected by the distraction rod. And after that, when we have corrected the varus deformity, we tighten the fragment. And after that, what we do, we try to correct the rotation deformity. So what we do, we put the hole of the distal frame into another hole. Here we have had 2 holes because movement was not possible in the movie. So as soon as we are tightening the proximal threaded rod, what happens? The external rotation or derotation of the distal fragment takes place. So this is the movie. So first of all, one olive is passed from the posterolateral surface, and the pre-constricted frame is attached and tightened. After that, another in the proximal link, another oil is passed from anterolateral to posteromedial there. So there is no vascular. This is done at the level of the anterior fold. So this is tight. Then we give tension to the first olive wire.
Dr. Agarwal, please wrap up because we have already
One-
finished the time. So one more
sir.
presenter is there.
So after that, we give tension to the second olive wire. You can see that. And after that, we give another wire from the medial epicondyle to protecting the ulnar nerve, because in the varus is there, so ulnar nerve can be very well there. Now we are giving the tensioning of the third wire, and after that, to supplement more rigidity, we give the 2.5 millimeter to put a half pin there, that the lateral condyle, and insertion of the 4 half pin is in the lateral condyle is done, and after that, another drilling is done to supplement the another half pin distal to the proximal link. So you can see that here another wrench, the hole is done, the half pin is done, connected with the 2-hole wrencho. Normally we put our half pin with the hand. Here we are just showing in the model. And after that, you can see that everything is tight and well stabilized. And after that, what we do, we remove the hinges there, and we do the osteotomy, loosen the posterior hinges so that we could get space for the osteotomy. And now we are going to do drilling by 2 mm. There should be no shattering of the fragment. And when we have done the osteotomy in 3 directions, so that to complete the osteotomy, and after that we do the supracondylar osteotomy. Now all the threaded rods and everything is corrected, now removed, so that now we are going to have the derotation of the fragments. So we applied 4 threaded rods there, and after that the motor unit and the anterior and posterior hinges are removed there, that you can see there. And it is supplemented by now there are 4 thread rods are there.
Dr. Agarwal, please, because we don't have time. Dr. Agarwal, please.
1 minute, sir. It has been finished there. So after that, we remove everything. And what we do now, we derotate. Derotation is done by holding the thread rods there so that the derotation is corrected. Thank you very much.
Okay. Dr. Junjunwala, can you hear us? Dr. Junjunwala. Dr. Junjunwala, are you there?
Yeah, I'm there.
You be ready with your presentation. Now, Dr. Agarwal's presentation is open for discussion.
Dr. Agarwal, how you were able to correct the deformity with the four threaded rod in place?
You know, 4 rods, when we first of all, we corrected the deformity with 2 hinges and motor unit.
Sir. While you were correcting the deformity, your 4 threaded rods were in place.
No. Pardon?
How could you correct the deformity with 4 threaded rods in place? There are 4 threaded rods were also in place.
No, sir. You are confused, because first of all, we correct the varus deformity by 2 hinges and 1 motor unit. After that, when we have corrected the deformity after 2 weeks, when good amount of the callus is formed, so then we do internal rotation deformity by putting the 4 thread rods and putting the half in the clockwise into another hole.
Instead of that, you could have used translation device.
No, sir,
rotation device. You could have used rotation construct.
Yeah,
that would have helped you.
No, I tell you, initially we used to have the derotation at the acute stage. But the bone fragment, because the bone is very thin at the osteotomy site. So
that is why one should use a rotational construct so that your bone fragments may not get displaced.
No,
they will be almost at the same place where they are.
That is done after 2 weeks. 1 whole rotation gives us the 10 degree of the rotation. So another, if there is a 20 degree of the internal rotation, we can do the correction after the 1 week. This is a wonderful technique, because all the open way techniques, even the French osteotomy, literature says that this is a 30% poor results.
Dr. Agarwal, because we have just 10 minutes, can Dr. Junjunwala, we can call him. Dr. Junjunwala, we cannot take questions now because we have only 10 minutes. Can you stop screen share, Dr. Agarwal?
Just Jitendra, I am telling you, he is doing it when there is a callus formation already. And when the hinges are removed, when the rods are put, you can put one hole next to the previous rod.
Dr. Junjunwala, please share your screen.
Yes.
We have just 10 minutes. We have to wrap up.
I will finish in 5 minutes. Okay. say level of deformity correction, if the deformity may be difacial or maybe metafacial or epiphyseal. The metafacial and epiphyseal is called juxta-articular deformity. Now for juxta-articular varus deformity of the tibia, you can see here, you can do the drawings like this, and here it is 37 degrees, and if you do the osteotomy and keep your hinge at this level, then you will get a second deformity like this. But if you put your hinge at the cora level, the cora is at the joint level. And if you put your hinge and do the osteotomy here, you get translation and you get a correction of the deformity perfectly. So the principle is that wherever the cora, the hinge should be at the cora or at the apex according to the Heidelberg. Okay? So this is a case of, you can see both ankles. This is the foot has gone in the rail track and the 5 years back, and there was a epiphyseal injury to the lower end of tibia, and patient developed gradually varus deformity plus shortening. So we did planning like this. We had a mechanical axis of the shaft of the tibia. We did distal proximal, distal axis. This is the distal axis by doing a 90 degrees angle to the epiphyse here, 90-degree angle, and then we did this distal axis so that we can calculate the 22 degrees magnitude of the deformity. So this is the epiphyseal line of the tibia. This is the ankle joint epiphyseal line of the tibia, 90 degrees. And LDTA is 90 degrees. And the frame was put. These are the hinges were put. But yeah, this deformity correction was done in 94. When I just started doing the Ilizaro, just about a year before. And I was not that well accustomed to put the hinges, and so therefore there is a slight deformity. The translation could not occur here because the hinges were put at the osteotomy site, at the osteotomy level. At the osteotomy level, and therefore translation could not occur. If I would have put these hinges at this level, I would have got a translation and I would have got a proper correction. Here there is a slight valgus correction. So important is that the hinges must be put at the cora or apex, and you can plan it according to the osteotomy cannot do at the joint level. Osteotomy has to be supramanular, and therefore hinges must be at the apex or cora at the joint level. Thank you.
Thank you, Dr. Junjunwala. We have time only for 2 questions. So, any panelists? Anyone?
It shows he is having a proximal tibial deformity.
Media.
The clinical picture shows he is having a tibia varus deformity.
Yes, Dr. Junjunwala, Dr. Vasudevan's observation is correct. In the proximal part, there is a varus deformity. It looks like, can we see the full length X-ray again, Dr. Junjunwala?
Yeah.
No, the full length X-ray.
Final full length is.
No, I don't have.
Yeah, but there is a residual deformity in the upper part, sir.
Yeah, I have not measured that, so I don't know.
Okay. So, any other question for Dr. Junjunwala? Dr. Junjunwala, can you stop your screen share?
Sorry?
Can you stop your screen share? Yes, Dr. Ravi Chauhan.
Yes.
Dr. Ravi, can you hear me?
Ravi Chauhan.
Ravi?
Yes, sir.
Put the brochure, the flyer.
I am sharing it, sir. By that, you can take the question. Also.
Okay, now it's a very good news that Professor Dror Pele has agreed to do a webinar with us. It will be a real blockbuster webinar. So we will be doing on Sunday, coming Sunday 10th from 7 to 10 p.m. And this is a combined webinar from Pediatric Orthopedic Society of India and Asami India. So there will be panelists. This is a combined webinar of two associations. So it's a very, very, good news and lot of prestige and for us. So I will show you the flyer now.
So there is some issue actually in this now.
It's not coming, Ravi?
Yeah, actually the PDF file now. Just I'm trying.
Just paste it on the PPT.
Yeah, just time.
Ravi, if you are not can show, just mail to me or send to me.
So for this, we have chosen selected panelists. So we cannot have Dr. Dror Pele will first present on the super hip operation, and his presentation will go for 45 minutes, and then we have questions from the panelists and from the audience. Now the second part is that he will explain about the super knee surgery, and then we have questions. So this event will be an international event, and it will cross the boundaries of India and till Europe and all this. This is the flyer which we have made just now. So this is it's a pleasure that it is a combined effort, and these OC people contacted me. So we will have two moderators, myself and Dr. Dhiren Ganjawala, and panelists will be 3 from Asami and 3 from POSI. So these have been selected by Professor Dror Pele. So Dr. Ashok Johari will represent POSI. Dr. Mangal Parihar will represent Asami. Milind Chaudhary will represent Asami. Dr. P.N. Gupta is on both sides. So he is also involved because this was effort of Dr. P.N. Gupta. Dr. Chirian Kaur is also on both sides, Asami and POSI, and Dr. Ruta Kulkarni is also both sides. So it's a mega, webinar. So I think we all should make it a success.
Can I stop sharing, sir?
Okay. Now we'll stop the live. Dr. Sham.
Yes, sir.
We can go off.
Shall I stop the live streaming, sir?
Yes.
Okay, thanks.